Good morning, everyone. Today is my surgical clinics in Jaipur Surgical tutorial. Can you see my screen? Am I audible clearly?
Yes, I can see and I can hear you. Yes.
Okay, sir. My case is 56-year-old male from Gangapur, Rajasthan, and farmer by occupation, presented with complaint of progressively increasing jaundice for an abdominal pain for 15 days. Patient was relatively asymptomatic 3 months back. Then he noticed yellowish discoloration of eye and urine, which was progressively increasing intensity. It was associated with progressively increasing generalized pruritus, and he also passed clay color stool for 3 months. He gives history of nausea, loss of appetite, and loss of weight 10 kg in last 1 month. I would like to know the recent weight of this patient also. For the last 15 days, he has right upper quadrant continuous vague pain, which is not radiating, mild in intensity, and relieves with medications and not related to food intake. He has generalized weakness and melena for 15 days and no history of giddiness or palpitation. There is no history of fever with chills, vomiting, abdominal distension, altered sensorium, and hematemesis. I would like to know the history of breathlessness on exertion or rest, chest pain, and prodromal symptoms like myalgia and malaise also. Patient is a known case of hypertension and taking metoprolol and atenolol, and he is recently diagnosed diabetes mellitus for 1.5 years and taking oral hypoglycemic medication in the form of glimepiride and metformin, and there is no recent change in the medications dose, all type of medications also. He is also known case of coronary artery disease and underwent a PTCA procedure in September 2020. Since then, patient is taking tablet aspirin, clopidogrel, and rosuvastatin till now. No history of similar complaint in the past, and no history of any blood transfusion, COPD, renal disease, and native medicine impact. Patient is taking mixed diet. There was a history of alcohol intake, but he stopped 2 years back. And he is also BD smoker, taking 20 BDs per day for 20 years, and unaltered sleep and better bowel habits. And there is no significant family history. Should I summarize my history, sir?
Yes, please.
My case is a 56-year-old chronic smoker male with hypertension, recent onset diabetes, and CAD, presented with a progressively increasing obstructive jaundice and pruritus for 3 months. For the past 15 days, he has vague, continuous pain with mild intensity in right hypochondrial region and also passes melena. He has significant loss of weight of 10 kg and also loss of appetite, and he does not have any history of fever with chills and vomiting. He underwent PTCA procedure in September 2020 and receiving clopidogrel and aspirin currently.
Okay, let's go back to your first slide.
Yes.
Yes, so here.
Sorry, sir, I can't hear you, sir.
You said that, why do you want to know the recent weight?
Okay, I would like to recent weight because I would have idea whether what was the previous exact weight and what was the nutritional status of the patient, and if there is a current weight is very low, maybe patient has lost very much weight, and the nutrition maybe he has a poor nutrition.
No, but you don't think that 10 kg weight loss in 1 month is significant?
Yes, it is significant, sir.
That itself is significant. So whatever be his current weight or normal weight doesn't really matter. 10 kg in 1 month.
Yes, it's significant.
Very, very significant. So I don't think that is of much importance. Okay.
Yes, sir.
Next. Sorry, the previous one. I'm sorry. Where did you mention melena? You mentioned melena. Yes.
Last
melena
point, sir.
Okay.
Yes.
Next, please. Why ask about these prodromal symptoms like myalgia?
Because to cover the all basis of this jaundice, the patient had history of jaundice. That's why I'd like to rule out any hepatitis history was there or not. That's why I asked myalgia.
that is all right for an undergraduate or maybe a student, but 3 months progressive history of clinically obvious obstructive jaundice. Are you really worried that this could be hepatitis? You have hepatitis in your mind, isn't it?
Yes, sir, but based on history, I can rule out that only on the based on obstructive history. Clear?
Yeah, so I don't think that is. It just shows that you have asked it as a routine without giving a thought to the clinical picture. In this, suppose the history was only 2 weeks, then I would agree with you. But here there is a 3-month history of jaundice, so I don't think hepatitis comes in our differential discussion at any stage. Okay.
Yes, sir.
Next slide. So you say that he was diagnosed with diabetes 1.5 years ago, but in your summary you mentioned recent onset diabetes. What is the definition of recent onset diabetes?
Any diabetes onset within 2 years of within 2 years, it is also considered as a recent onset of diabetes.
Check on that. I'm personally not very sure, because recently when we were reviewing the topic of exocrine function, endocrine function of pancreas after PD, I thought it is 6 months, but check on that. Anybody else, any other would like to comment on that, that what is the accepted definition of recent onset diabetes? Is it 2 years or is it 6 months? So since I'm not sure, please check on that.
Yes, sir. Yes, sir.
Next, please.
Definition, sir. Hello. Morning, sir. Morning, Dr. Ajay here, sir.
Yes, yes, please.
Yeah. Sir, as per definition, it is 2 years, sir. It is not changed. So we have been thinking about it that for a post-PD diabetes, it should be a recent onset diabetes post-PD. But for it is usually used for chronic pancreatitis, so it is 2 years only.
Okay, so Avadh, you are right. It is 2 years. Okay. Yeah. Next. Go before. What family history specifically did you ask for in this case?
Ask for the sir, if any malignancy in the family or related to any malignancy, I asked for, especially for the pancreatic malignancy.
Yeah. So say, actually, this is the question which you will ask when you come back after the examination or at a later stage. Because if your differential diagnosis includes CA of the pancreas, then especially if it's a relatively younger patient, then definitely.
Did you take history for
out of all the malignancies which cause obstructive, malignant surgical obstructive jaundice, CA pancreas, CA head pancreas will or may have some familial predisposition, not the others.
Yes, sir.
Okay.
What about polyposis syndromes? Did you take any history of polyposis syndromes? What is the differential of polyposis syndromes with your current history?
Patient does not have any history of any altered bowel habit was not there. Second thing, age of the patient is not usually this patient present with earlier in the age group in the polyposis syndrome cases. Although yes, polyposis syndrome cases, pancreatic malignancy can appear in the especially in the Purzagar cases, and it usually appear in the 40 or 50 years of age group can appear, sir.
What about familial adenomatous polyposis? Isn't it also
yes, sir,
predisposed to periampullary carcinoma?
Yes, sir. FAP also can predispose to periampullary, especially yes, sir, periampullary carcinoma.
Yeah, so it can have variable penetration. It has 100% penetrance, but the age at which it occurs can vary. Usually it is in 20 to 30 age group, but that doesn't mean it cannot occur at 40 and become symptomatic.
Yes, sir.
And especially if there is treatment history for FAP, one of the follow-up paradigms that you have to keep in mind is periampullary carcinoma.
Yes, sir. Yes, sir.
Yeah.
So what Dr. Desai is trying to tell you that if you have a relatively young patient where you are suspecting a periampullary carcinoma, you should ask for history to suggest familial adenomatous polyposis. And just saying unaltered bladder habits is not enough. You should have then said that there is no history of passage of blood and mucus in the stool over a long period of time. The way you present a negative history also tells me what is going on in your mind.
Yes, sir.
Okay. Similarly, go back to your past history in this case. Yeah. So suppose, obviously, since it is surgical malignant obstructive jaundice, carcinoma of the gallbladder will come as a differential diagnosis at some stage.
Yes, sir.
So again,
Sir, I can't hear you, sir.
you should clearly mention this, which suggests biliary colics. That should clearly come out. I'm saying whenever carcinoma of the gallbladder becomes a differential diagnosis, in the past history, you have to make a special mention that there is no history to suggest repeated attacks of.
Yes, sir.
And same way, if you have a relatively young patient, where cholangiocarcinoma becomes a differential diagnosis, then you think of what is the underlying condition which can predispose to a cholangiocarcinoma?
Primary sclerosing cholangitis and colloidal cyst can lead to cholangiocarcinoma in the younger age group of patients, sir.
Yes. So your past history should include statements which suggest to us that you have thought of these possibilities and you have looked into these possibilities.
Yes, sir.
Yes. Go to the summary. Yeah, I think you've included most of the relevant points in the summary. So what do you make out of this history?
So based on the history, my diagnosis will be obstructive jaundice due to malignancy, and more likely first and second will be like carcinoma head of the pancreas and the carcinoma gallbladder. But also in the third possibility, I'll keep ampullary carcinoma and very lower down, sir, cholangiocarcinoma, sir. But carcinoma head of pancreas and the gallbladder malignancy will be my prior diagnosis, sir.
So I don't think we have a debate with you on malignancy, but here, just to ask you, just to put you in a corner, could this be all benign?
Sir, it's less likely because short duration history with progressively increasing jaundice and significant loss of weight that favors towards the malignant pathology, but it can be, sir, but very less likely, sir.
Yeah, unlikely. So you should say, based on this history, my clinical diagnosis would remain malignant surgical obstructive jaundice. Okay. So you said carcinoma of the pancreas first.
Yes,
why
sir.
do you say so?
Did you take past history of surgery?
Yes, sir, there was the no past history of any surgery, sir.
How would you think it would affect this diagnosis? Where would you get this kind of condition?
Okay. When patient had a history of sometimes cholecystectomy and they have missed any incidental misdiagnosis of gallbladder malignancy, that can lead to this kind of picture.
Yeah. What about biliary stricture due to whatever cause, late presenting biliary stricture? Is that possible?
Yes, sir. In the chronic pancreatitis patient, also sometimes with biliary stricture, that can lead to malignancy, sir, a long period of time. Sir.
Yeah. What about hilar cholangiocarcinoma? Have you considered that possibility?
Hilar cholangiocarcinoma, sir, very lower down. I'm considering as a cholangiocarcinoma because usually they do not present with pain, sir. The pain is very unlikely feature in hilar cholangiocarcinoma. But I can keep it at a lower diagnosis, sir. But I'll consider it, sir. At this stage
Yeah, but not because of pain. Pain has got nothing to do with it. Cholangitis will cause pain. Yes, infiltration will cause pain. Metastasis will cause pain. Yes, so sir. Pain itself, you shouldn't make it so strong.
Yes, sir.
The only thing that tells you that there is pain is if there is biliary colic, that there could be gallbladder stones which have slipped down, and this is a case of CVD stones.
Yes, sir.
Yeah.
So again, going back to the question that why do you say it is pancreas first?
First thing is the patient is chronic smoker. Second thing is progressively increasing obstructive jaundice, and also he has a recent onset of diabetes mellitus, which is more favoring towards the pancreas malignancy, sir. But I give carcinoma gallbladder also as equal only, but pancreas little bit higher up, sir.
Yeah, so progressive jaundice suggests malignancy. It doesn't suggest pancreas or gallbladder or cholangiocarcinoma. In all these conditions, the jaundice will be progressive. So
yes, sir.
When I'm say pancreas, you should not say progressive jaundice. That point you should have mentioned when we talked of benign versus malignant. Now we are talking out of the malignancies, why pancreas? So points in favor of pancreas could be pain, could be melina is because of duodenal infiltration. More likely in a pancreas lesion. Significant weight loss.
Yes, sir.
And recent onset diabetes.
Yes, sir.
So these are points, soft points, subtle points in favor of pancreas.
Yes, sir.
Okay. Points in favor of gallbladder.
Okay. That pain is this is a vague right upper quadrant pain, which is mild continuous pain. It may be, sir, gallbladder malignancy that lead to infiltration in the liver, sir. Because of that, the patient can have this kind of pain, sir. So that's it, the reason I'm considering gallbladder malignancy. And second thing, patient in the North India side, I don't know exactly where Gangapur is, but it mostly in the upper part of Rajasthan. So that is also one possibility that there is a malignancy in gallbladder, sir.
Yeah, so again, some points from where the patient comes or where he has been living, and the fact that pain is in the right upper quadrant rather than in the epigastrium. It is not typically suggestive of pancreatic pain. So these are points which you would say are in favor of gallbladder. Periampullary and cholangiocarcinomas, by and large, to begin with, are painless progressive jaundice. In cholangiocarcinomas, some texts mention and some teachers also agree that in some patients you may get a history that pruritus precedes the onset of jaundice. So I don't know how much weightage you can give to that. In papillary type of periampullary carcinoma, where the tumor is at the papilla, sometimes the tumor sloughs off, it temporarily relieves the biliary obstruction, and patient can present with melina, which is associated with some transient temporary decrease in jaundice, which then again rises again. But these pictures are not very frequently seen. If they are there, you can use them as a point in favor, but if they are not there, you cannot say that it is not a periampullary carcinoma. Okay?
Yes, sir. Yes, sir.
Okay. At this stage, any other teacher wants to say anything? Any other student wants to ask anything? Interpretation of history?
What do you think is the cause for pain? You said something about liver infiltration causing pain. That's not the case. It's actually distension of the Glisson's capsule, which occurs when there is obstructive jaundice of any kind, especially hilar cholangiocarcinoma, mid-CVD cholangio, and carcinoma head of the pancreas. Because of distension of the liver, you can get pain.
Yes, sir.
Yeah.
One more thing, sir. I'm audible, Avadh?
Yes, sir. Yes, you're audible, sir.
As Dr. Kapoor mentioned, you should have mentioned with the melina, did the jaundice decrease in your history or not? Because that may be a pointer.
Yes, sir.
Yeah, so when you mention that it is progressive jaundice, it is good to add that there is no history to suggest any transient decrease in the severity or level of jaundice. Okay.
Yes, sir.
Fine. Let's move on.
In general clinical examination, my patient is considered cooperative and well-oriented to time-patient person. He is moderately built and nourished with BMI of 23, the ECG performance status of 2, and is well hydrated and afebrile. Icterus is present. I would like to know the status of pallor, and there is no cyanosis, generalized or supraclavicular lymphadenopathy or pedal edema. Pulse rate is 86 per minute, blood pressure 140 by 80 millimeter of mercury, and saturation 96%. No signs of chronic, I would like to also know, any signs of chronic liver disease or any scratch mark in abdomen or the legs, sir.
Why do you want to know the height and weight? How is it going to change your plan?
Yes,
Is
as a
BMI not good enough?
yes, BMI is good enough, sir. But it will give idea about the build of the patient, sir. That height, especially the height of the patient, sir.
How does it matter whether he is short built or tall built? Does it matter?
Is not going to much make difference, sir.
Yeah, I can't think of anything which will affect this. Similarly,
Yes,
go back to general examination. So why do you think that when this case was given to you, pallor was not mentioned? Could there be any reason?
Yes, sir. Because in the very deep jaundice, very difficult to interpret the pallor, especially in the jaundice patient, as we regularly see.
Yeah, I don't remember. I think we were taught in undergraduate days that there are some ways that you can look for pallor in presence of jaundice. Anybody can tell that? Where to look for pallor if the patient is deeply jaundiced? I don't remember. Yeah. Okay. You expect signs of chronic liver disease in this patient?
No, sir. Not not in this patient, sir. But as I covered all the basis for jaundice, sir, there is maybe some possibility because patient was alcoholic in the past. So maybe some signs of early CLD may have developed, sir. That's why I'd like to consider in the examination part. But as a history, it's not showing any pointer towards chronic liver disease.
Not only that, the duration of jaundice, it is only 3 months. And in which patients when you say chronic liver disease here, what do you mean? What will be the underlying pathology?
Yes, sir. In the cholangiocarcinoma, there is a chances of predisposing chronic liver disease may be there, sir. Or any long duration of history in the past, there is maybe some past history of jaundice. There can be.
Yeah. So basically, cirrhosis. Which patients are more likely to develop secondary biliary cirrhosis?
If patient have obstructive jaundice undrained for at least for 6 months of period of time, sir, or any.
So long-standing recurrent biliary obstruction with recurrent episodes of cholangitis. So typically it is seen with benign biliary obstruction.
Yes, sir.
Usually malignant biliary obstruction does not cause. It can, even 3 months it can cause. The usual picture is long-standing recurrent biliary obstruction with recurrent episodes of cholangitis.
Yes.
Okay.
Yes, sir.
You want to know about scratch mark present on abdomen and legs? Why do you want to know that?
It just give idea about how severe the pruritus is there. If it is localized to one area or in generalized abdomen and the different part of abdominal cotton and also body parts is there, then it helps me in the further.
So you decide the severity of pruritus by the extent or by something else?
Yes, also the quality of life and sleep disturbance, that also I will consider along with this.
That is more important, whether it is interfering with the day-to-day activity, whatever the patient does. Suppose he does something where he has to use both his hands. Suppose he is a rickshaw puller. Now he can't scratch. So, or is it interfering with the sleep? So it is not the extent of pruritus. It is the interference with the quality of life. That is more important, which will decide whether you have to palliate it or not. Okay?
Yes, sir.
Next, please.
Patient's abdomen is flat with centrally placed inverted umbilicus, all quadrant move equally with respiration, no visible scar, sinus, any peristalsis, dilated veins or fullness, and hernia orifices are normal, no flank fullness. All inspectory findings were confirmed in the palpation. There is no tenderness in abdomen, palpable gallbladder in right hypocontinent region, which appear as a non-tender oval swelling of 4 into 3 centimeter in size, form smooth on surface, moves with respiration, and upper water could not be felt. No hepatosplenomegaly and genitals are normal. So
this, go back. This palpable gallbladder, what is it? What is your assessment, interpretation?
Yes, sir. It's just a distended gallbladder that I could palpate on the abdomen. There is no surface irregularity is there, sir.
So basically what I'm trying to say, that when you palpate a lump in the area of the gallbladder, you say it is a gallbladder lump. So theoretically speaking, it could be an SOL in the liver also, but
Yes,
we
sir.
take it as gallbladder. And you have to differentiate between a distended gallbladder, which is a normal gallbladder, which either because of a block at the cystic duct or at the lower end of CBD is distended. So it will be smooth. It will take the shape of gallbladder, piriform, oval shape. It will be soft in consistency, but it can be firm. Okay, so that
Yes,
is
sir.
how you differentiate. And if it is a firm to hard, irregular, nodular lump, which does not take the shape of gallbladder, which has no side-to-side mobility, then we describe it as a GB mass, which
Yes,
we
sir.
are pointing towards a malignancy. So in this case, you should say, I think this is a distended palpable gallbladder because
Yes,
of
sir.
block.
Because of,
Okay.
yes, sir.
Carry on.
There is a liver span of 12 centimeter in right mid-clavicular line. There is no ascites on percussion. Normal bowel sound are heard on auscultation. On per rectal examination, normal perianal skin, no pelvic deposit of mass felt. Fingers stained with yellow color stools. And CVS examination, I could heard S1, S2 normal. And respiratory system is also normal with adequate bilateral electrics.
You see, as I say again and again in these sessions, you have different types of examiners. An examiner like me would accept when you say no ascites, but there are some examiners which still insist that no ascites is an interpretation. It is not a finding. So they would prefer that you say that there is no dullness in the flank, and then you say there is no ascites. So be a little cautious. I would suggest play safe and describe the findings and then give your interpretation.
Yes, sir.
Yeah. Carry on.
I summarize my history, sir. Is a 56-year-old chronic smoker, male with hypertension and recent onset diabetes and coronary artery disease, presented with progressively increasing jaundice with pruritus for 3 months. For the last 15 days, he has continuous pain in the right hypochondrial region with mild intensity and also passes melena. He has significant loss of weight and appetite. He does not have history of fever with chills and vomiting and underwent PTCA procedure in September 2020 and receiving clopidogrel and aspirin currently. On examination, he is moderately built and nourished with ECG performance status of 2. He is having icterus and palpable, normal distended gallbladder is palpable without any signs of ascites and hepatosplenomegaly. On per rectal examination, yellow color stool present and no deposit.
Yeah, whosoever has prepared the history, you could still cut down on some words. See, when summary. So you could easily say that vague, mild, continuous right upper abdomen pain for 15 days with melena. So you could cut down on some words. There's no need to say he has. So what I'm saying, summary has to be very concise. You should use as minimum words as possible. Yeah.
Yes, sir. Yes, sir.
So now what is your diagnosis?
Okay. Based on the history, my diagnosis sequence will remain the same as obstructive jaundice because of malignancy. First, the carcinoma head of pancreas I'll keep first, and also carcinoma gallbladder in the second, and periampullary and cholangiocarcinoma at the lower down, sir.
So, in the examination, is there any point which now supports your first diagnosis more than the history?
Yes, sir. I could not palpate any lump in the gallbladder, sir. It is only just distended gallbladder. I could see that that's why I can keep carcinoma gallbladder second down, but I completely cannot rule out carcinoma gallbladder because in the sometime neck malignancy also we have distended gallbladder as a normal gallbladder we can see, sir.
So how can you have a distended gallbladder in gallbladder cancer?
Yes, sir. If there is a carcinoma gallbladder with neck region, especially that block the cystic duct, there can have a distended gallbladder, sir.
Yeah. So your answer should be that in large majority of cases with gallbladder cancer, a firm to hard gallbladder lump is palpable, but in patients with gallbladder cancer with a tumor at the neck, which is blocking the cystic duct, clinically a distended gallbladder may be palpable, which then looks like a lower end CBD block. So clinically, in this case, you cannot say whether it is CA head pancreas causing a distended gallbladder or whether it is a gallbladder neck malignancy which is causing a distended gallbladder.
Yes, sir.
Does this rule out some diagnosis?
Yes, sir. Hilar cholangiocarcinoma we can rule out at this stage because there is a palpable gallbladder is unlikely in that group of patients.
But you have still mentioned cholangiocarcinoma. Which cholangiocarcinoma?
Yes, sir. It's can be, sir, but distal cholangiocarcinoma we cannot completely rule out with this history, sir, because in this patient we can have palpable gallbladder. That is just still consider it as a lower in my diagnosis.
Yeah, but distal cholangiocarcinoma will be included in the definition of periampullary carcinoma. So
Yes,
even
sir.
a mid-CBD cholangiocarcinoma, which is causing a block of the cystic duct, would behave the same way.
Yes,
So
sir.
the only thing which is ruled out by a distended gallbladder is a gallbladder cancer in the fundus or body and a hilar cholangiocarcinoma. Rest
Yes,
other
sir.
possibilities still can remain.
Yes, sir.
Okay. So based on your clinical assessment, what is your overall assessment and plan of management of this patient? What do you think this? We agree with your diagnosis that this is CA head pancreas. What do you think? Is it resectable?
Yes,
Is
sir.
it metastatic? Is it advanced? What?
It's look like, sir, advanced malignancy to me, because first, if it is a CA head of pancreas, pain with a CA head of pancreas is also one marker that patient can have advanced malignancy because of involvement of retroparietal nerve plexus. And even if it's a gallbladder malignancy with obstructive jaundice also considered as a locally advanced malignancy. So because of based on this history, it may be a advanced malignancy, sir.
Yeah. So let's restrict our discussion to carcinoma of the head of the pancreas. How do you classify carcinoma head of the pancreas from the point of view of management?
Okay. It can be, sir, resectable, then borderline resectable, or the locally advanced or metastatic disease. Based on my further evaluation, I can differentiate carcinoma pancreas in this group, sir.
Very good. Very good. So based on clinical assessment, in this patient, which group do you think this patient is likely to belong to?
Maybe, sir, borderline. Sorry, and maybe, sir, locally advanced or a borderline resectable group, sir. Based on this.
So your answer should be that borderline resectable actually is a radiological definition.
Yes, sir. Yes, sir.
All of them are radiological definition, but borderline is a purely radiological. So
Yes, sir.
Yes, because of history of pain and also significant weight loss.
Weight loss.
He's lost a significant amount of weight. These are again very soft pointers that this is likely to be locally advanced. There is clinically no evidence of Did you mention supraclavicular nodes in your general examination?
Yes, sir. I have mentioned, sir, in examination.
I missed that. No, that's fine.
Yes,
I missed that. Okay.
Yes, sir.
Yes. Good. Good. So clinically, there is no evidence of metastasis based on the history of pain, which actually has happened recently. It started without pain, but now there is pain and a significant weight loss, 10 or 15 kg in a month. The pointer is more towards locally advanced rather than early resectable, although you cannot say that with definitely. Again, I would say that in MCH exam, don't take it as a question answer session. So when a question is asked, majority of questions will not have a single correct answer. What we want to know is what is thought process, what are you thinking about? So that is how you should answer many of these questions. Okay.
Yes, sir.
So if this patient comes to you in the OPD, what will you do?
I would like to do, sir, 2 sets of investigation in this patient. First, for this routine ancillary investigation for the help me to evaluate the general status of this patient and further management. That is CBC, renal function test, liver function test, PT with INR, and another investigation to make my diagnosis confirm. For that, I will do ultrasound abdomen in this patient, sir.
Do we have the ultrasound report?
Yes, sir. Can you see, sir?
Yes.
This ultrasound shows the liver is normal in size with normal ecotexture, and gallbladder is distended with 14 mm stone and sludge inside. CBD is 14.8 mm and solid lesion of size 43 into 43 millimeter in head of pancreas with few peripancreatic and periportal lymph nodes. Largest is 26 into 19 millimeter in the size, sir.
So how does it change your perception, this ultrasound report? Is there anything
Yes,
which doesn't fit in with what you said so far?
Yes, that carcinoma gallbladder is because there is no mass lesion in the gallbladder. The gallbladder I can rule out at this stage of time, sir. And the CBD also dilated to cholangiocarcinoma. The hyalocholangiocarcinoma also is not a possibility, though. Malignancy of head of carcinoma in the head of pancreas is more favorable diagnosis based on this ultrasound, sir. And with also there are the lymph nodes in this localized area which are very large in the size also. That is also one marker toward the carcinoma pancreas, maybe locally advanced or maybe at a higher grade, sir.
Yeah, so if I were you, I would say that the stone in the gallbladder is an unexpected finding, but I don't think it changes my thought process because it is probably just a coincidence, gallstones being so common in the population. I would have preferred to see the extent of CBD dilatation. It is only mentioned 14.8, and we know that most radiologists do not differentiate between CHD and CBD. So it would have been better if the radiologist had said CBD dilated till the lower end.
Yes, sir.
Okay.
Yes.
And obviously there is a lesion in the head of the pancreas because if it has been detected on ultrasound, it means it is a significant lesion. And the lymph node seems to be significant because it is fairly large.
Yes,
especially in the absence of history of cholangitis. Suppose the patient had cholangitis and then you see a lymph node, you are not sure. But since there is no history of cholangitis and you have a 3 centimeter node, it is very likely that it is significant. What else is missing in the ultrasound which you would have preferred to know?
First is any free fluid in the abdominal cavity.
Okay.
No.
Anything else in the pancreas you would have?
Yes, pancreatic duct dilatation and diameter also.
Yeah. So you want to see both
pancreatic entropy.
If both the ducts are dilated, that is what is known as a double duct sign. Earlier, the double duct sign was classically described for pancreatic head cancer. But in pancreatic head cancer, when the two ducts are dilated, they don't meet each other. Because in the area of the mass, the ducts are not seen. Whereas in periampullary carcinoma, the two dilated ducts almost meet each other. So a good sonologist can easily differentiate that. And especially if a mass is also seen, then he or she can say that this is head of the pancreas rather than a periampullary carcinoma. Okay.
Yes, sir. Yes, sir.
Also, for the sake of completion, you should have said that I would have preferred if the report had said that there are no SOLs in the liver.
Yes, sir.
Okay.
Yes.
So these days, if you have an online exam, you have to rehearse this also, that whatever information is given to you, you have to say that this is what is missing and this is what I would have liked to know. Although we presume that if it is not mentioned, it is not there, but still you will score some points if you point out those things.
Yes, sir.
Okay. So after this ultrasound, what do you want to do? So based on the ultrasound,
just one question,
now
sir.
what is your classification of the disease?
Just one question from me.
Yes, yes.
Yeah. What is Courvoisier's law and what is this case? In this case, how would you apply Courvoisier's law?
Yes, sir. It is for this case, we can apply Courvoisier's law because in any cases where obstructive jaundice with palpable gallbladder, it's seldom due to stone, sir. That is the Courvoisier law. And here there is a malignancy in the pancreatic lesion. We have palpable gallbladder. It is more likely the malignant etiology, sir.
But there are stones as well.
Yes, sir. There are stones.
But there are stones as well.
Yes, sir. Only gallbladder stone does not exclude the Courvoisier's law. If we have gallbladder stone with CBD stone, like so double impacted stone in the CBD and also obstructed neck of the gallbladder, sir, then we can say there is a fallacies of Courvoisier law. In that benign condition also we can have palpable gallbladder, sir. But only gallbladder stone cannot exclude Courvoisier law.
Sure. Good.
So at this stage, any other teacher wants to ask or say anything before we move on? Anybody else? Okay, please. So based on the ultrasound, which group would you classify this carcinoma head of the pancreas into?
It difficult to say based only on the ultrasound, but it locally advanced as the size is 4 into 4 centimeter and with flat nodes without cholangitis.
Reasonably large mass, 4 centimeter is a large mass in the head.
Yes, sir. Yes,
and
sir.
Significant lymph node, more likely that this will turn out to be locally
Locally
advanced.
advanced. Yes, sir.
It is not metastatic. It is
Yes,
not
not
early resectable lesion.
Yes, sir.
Yes. Okay. What next do you want?
I would like to know the CBP and the renal function, liver function test of this patient, sir.
Let's have a look at them.
Patient's hemoglobin is 6.3. He is anemic with normal TLC and platelet count, sir. Maybe because of melena, he has a lower hemoglobin, sir.
So, in fact, you can say that although history of melena is only for 15 days, but very likely that he has been bleeding earlier also, resulting in a very low hemoglobin.
Yes, sir.
Yes.
This in liver function test, he has elevated total and direct bilirubin, obstructive pathology, and with elevated alkaline phosphatase. SGO2 is elevated 162 with 109 of SGPT, and also albumin is 3.9, which is normal, and normal synthetic function in the form also INR is also normal. It is 1.1, sir.
But you didn't say anything about the enzymes, why they are elevated. You have to tell us.
Yes,
we can
also
see that they are elevated, but you have to give the analysis.
Enzymes can be this mild elevation of enzymes can be there in this obstructive jaundice patient. The SGPT may be elevated, and that SGOT higher side than SGPT because maybe because the patient had history of any alcohol intake that may have some alcoholic hepatitis in the past that may be resolving. That is also one possibility. And third possibility, maybe patient can have subclinical cholangitis that is not showing in the form of any fever on the rate TLC, sir. Only isolate elevated enzymes, sir.
Anybody can correct me that in alcoholic hepatitis, which enzyme is more likely to be elevated? I think it was SGPT, but check on that. Check on that. Okay.
Yes,
yeah. Next.
The
SGOT, sir. The SGOT SGPT ratio will be high.
Okay, so SGOT is more elevated than SGPT.
Yes.
Okay, so in this case, then you can say that since there is no history of fever and his counts were normal, we would have loved to see the differential count also, but then this is more likely to be due to his underlying alcoholic liver disease rather than cholangitis.
Yes, sir. In his renal function test, he is having normal urea and creatinine with at higher upper limit of sodium and the chlorine with elevated potassium is there, sir, which is 5.1, sir.
Okay, so what next?
I would like to first admit this patient, and with I'll consult with my cardiologist also for as patient recently underwent CABG procedure and he's having melena, and whether we can stop this clopidogrel for some period of time and also give some do cross matching and give blood transfusion to this patient, sir. Because 6.2 with recent CAD history is very low. My target will be 10 gram per deciliter hemoglobin will be there, sir.
So what is your plan of management for this patient? Why do you want to do all this?
Okay. Because in the further plan, I would like to do CCT abdomen with a pancreatic protocol in this patient, and also in the future patient may require some endoscopic procedure. So for that procedure, I would like to stabilize this patient in the form of hemoglobin and electrolytes which are elevated, sir.
But for the CT scan, you don't need to correct the hemoglobin. You don't need to stop the antiplatelet drugs.
Yes, sir.
Only require normal renal function, which is there. So all those things that you mentioned, they can and they should be done after you have done and seen the CT. Because suppose CT shows some findings which will totally change your plan of management. Okay.
Yes, sir. Yes,
So
sir.
I think that should come later. Now the next step should be a CT scan.
Yes, sir.
Now, since you are thinking of a carcinoma of the pancreas, which is most probably infiltrating the duodenum because there is a history of melena.
Melena. Yes, sir.
Which first, CT or endoscopy?
I will look.
Because you yourself mentioned
Yes,
that
sir.
you will do an endoscopy.
Yes, sir. That's why I will. I can do endoscopy first, but this hemoglobin is a very lower level, so may have some bleeding incident during the endoscopy. That's why I would like to do then CT scan first. I'll stabilize the patient. After that, I'll go for endoscopy, sir.
Suppose his hemoglobin was 10.
Okay, then I'll do endoscopy first, sir. These patients, because I can easily take biopsy and I can see any lesion because it looks like the pancreatic malignancy infiltrating duodenum, and I can have a tissue diagnosis, sir.
I probably would not agree, because most people would do a CT first, because if CT shows that there are metastasis or it is an unresectable lesion, then at the time when you are doing the endoscopy, in addition to taking a biopsy, you can always do a definitive palliative procedure also. And then if it is going to be a definitive palliative procedure, depending on whether the patient can afford, you can place a self-expandable metal stent. If it is a preparatory stenting, you can place a plastic stent. Also, once you place the stent and then you do the CT, you will have artifacts. So most people would do a CT first, decide what is the plan of management, and then go for endoscopy. Okay?
Yes, sir. Yes, sir.
Let's have a look at the CT.
Yes, sir. Wait a minute, I share my screen.
Avadh, while the CT is getting loaded, what CT will you order for this patient? What will you say, write on the prescription, what CT you want?
Sir, I will order for the pancreatic protocol CT of abdomen pelvis, along with also take chest CT scan, sir.
And what is the pancreatic protocol CT?
Sir,
So briefly, can you tell us what is pancreatic protocol? What does it involve?
Yes, sir. Pancreatic protocol CT, sir, that is a CT scan specially done for any SOL in the pancreas. In this case, we usually give a negative oral contrast and take CT scan phases. First as a pancreatic phase as 35 to 40 seconds, and portal phase that is the 65 to 70 seconds we take. And as a contrast, we give at a rate of 3 to 5 ml per second, about 100 to 120 ml of hydrogenated contrast we give, and less than 3 millimeter axial cuts of CT scan will take with arterial reconstruction we will give in the pancreatic protocol. Yes, sir.
So,
yes, sir.
Okay, please.
Very good.
Okay, sir. Wait. Can you see, sir, this video, sir?
Yes, yes.
Yes. This is the axial cuts of lower chest and also abdomen, sir, with non-contrast images, and positive oral contrast has been given in this patient. You can see normal contrast surface of the liver, and there is a distended gallbladder is present, so very hugely distended gallbladder. And I think, okay, there is no calcification in this area, and also there is a no free fluid, sir, in abdominal cavity, sir.
Yeah, so you should have said that I can see
Yes,
oral contrast, which I would not have liked to see.
Yes,
also, considering his alcoholism, you should say that liver contour,
yes, sir.
liver
Contour.
size,
Yes, sir.
lobes of liver are normal.
Yes, sir.
There is nothing to suggest atrophy, hypertrophy, or cirrhosis.
Yes, sir. Yes, sir.
Yeah.
Surface is normal. There is no changes of chronic liver disease, and there is no atrophy hypertrophic complex, and widening of hepatic facial is also not seen, sir. Yes. Wait a minute, I'll have to share again.
So, in which phase is the pancreatic mass lesion best seen?
Pancreatic mass lesion is best seen in sir late arterial phase, that is the parenchymal phase, because in this phase, parenchyma will have good enhancement and the pancreatic mass will appear hypodense in this area, sir, in this phase.
So classically, pancreatic ductal adenocarcinoma appears as a hypodense in the late arterial or the parenchymal phase where the normal parenchyma enhances.
Yes, sir. Sir, can you see, sir, this arterial phase? This is
Not yet.
Sorry, wait me. Now, can you see, sir? Yes, sir. Can you see, sir? Please?
Is it the arterial phase? Yes, yes. Okay.
Yes, it
Yeah,
is,
move.
yes, sir. Contrast phase, sir. Yes, sir. Okay.
Yeah. Play the
This is the axial cuts of arterial phase. In this case, I would like to more comment on the pancreatic pathology, sir, and arterial anatomy. Okay. Okay. There is a bulky head of pancreas I can see, sir, but difficult to comment. Then any hypodense lesion, I'm not especially I'm getting. Okay, in one area, in head and uncinate area, I can see some major uncinate area. I can see one hypodense area, sir, but not that typical of head of pancreas malignancy, sir. And in this photovenous phase, these are hepatic veins, liver parenchyma appear normal. There is a dilated intrahepatic biliary radicals. No SOL in seen in the liver, sir. Space occupied lesion, any metastatic disease not there in the liver. Significant distended gallbladder with wait a minute, I rewind it. There is a dilated, yes, a dilated CBD is there. That is low down. I can trace up to in the head of the pancreas, but after that, there is a complete cutoff is there. Means in the pancreatic common bile duct is obstructed. That's why in the pancreatic malignancy may have infected in that area, sir. And also
just below the level where you stop seeing the pancreatic CBD, you
Yes,
start
sir.
seeing that hypodense mass lesion
yes, sir, yes.
in the head of the pancreas.
Now also there is a large nodal lesion is there, sir, in aortocaval lesion area, but very lower down, sir. I can see just. Where ultrasound also they had seen that peripancreatic nodes are there. It may have misinterpreted this node as a peripancreatic, I think. Okay. So in this area, I think this is a very big nodal mass in the interaortocaval, just anterior to the aorta. I think there is a nodal mass in that area, sir. There is no ascites in this no ascites in the abdomen, sir. So based on this CT scan, I can say there is a mass in the head of the pancreas in pancreas in uncinate region, sir, with a hugely dilated common bile duct, and the CBD is there. And the liver parenchyma appears normal. There is no space occupied lesion or metastatic in the liver, and no ascites. And there is a large aortocaval node is there, sir. And
in a CA head CT scan, what is the most important finding which you have to look for?
Yes, then vascular relation also I would like to see, sir. Relation
Yeah.
to the SMV
So
and the SMS.
your reading of CT scan is incomplete unless
Yes, sir. Yes, sir.
the vessels which you forgot.
Yes, sir. Yes, sir. This is the portal vein. We can see, and this SMV splenic vein portal vein junction. Now it is SMV. Okay. Okay. I think there is a SMV. We can start, and there is a fat plane appears to normal, sir. In explain the one area. It may be if abatement is there, maybe less than 180-degree abatement in this area. Maybe there, sir. So SMV appears like that is a less than 180-degree abatement in the SMV, and this is the SMA, sir.
Yeah, but the mass lesion is
Yes,
far
sir.
away from the SMV and portal vein. The
Yes, sir.
SMV or
Yes,
portal
sir.
vein is the normal pancreas. It is not
Normal
the tumor.
pancreas, sir. Yes,
Tumor
sir.
is far away. So
Yes,
the
sir.
vessels are free.
Yes, sir.
So it is a locally advanced cancer
Yes.
because of the large lymph node, not
Yes,
because
sir.
of the vessel involvement.
Yes, sir.
Vessels are free. Both
Yes, sir.
SMA,
SMA is free.
and
SMA is
portal
also free.
are free.
Yes, sir.
Okay. Okay. I think we will have to stop. Only thing is that since it is still incomplete, if you want, maybe in one of the future sessions, you can inform Dr. Anand that you would like to discuss how
Yes, sir.
to proceed further in a patient who has locally advanced or borderline resectable, and then we can discuss indications, contraindications, neoadjuvant treatment, and I can ask one or two more experts to join. So
Yes,
please
sir.
let Dr. Anand know whether you would be willing to do that in one of the future sessions.
Yes, sir. Yes,
Any
sir.
other teacher would like to make any comments on the discussion so far? Any student? Okay, then
Can I
we
have
close.
Can I have one question, sir?
Yes, please.
Sir, in this in exam, can we justify this pain whether just a pancreatic head of malignancy pain because of the retroperitoneal nerve plexus involvement? Usually, the pain is the midline region because that is the visceral pain, sir. So, if there is vague pain right hypochondrium, as it is a vague pain, can we say it is a pain because of nerve plexus involvement that patient could not express localized? Can we justify like this?
I am not sure. It's very difficult to say what is the etiological kind of cause of the pain.
Yes.
So, and as Dr. Desai said, that there could be multiple causes of pain. Even stretching of the capsule of the liver will cause a dull, diffuse ache-like pain in the right upper abdomen or right lower chest. Local infiltration will cause pain. Ductal obstruction will cause pain. In this patient here, the stone, whether that is the cause of pain. So I don't think presence or absence of pain we can take to be of much importance in deciding either the diagnosis or the extent. The extent is decided mainly by the imaging. Yeah.
Thank you, sir.
Okay, so I think we can close, and please let Dr. Anand know whether you would like to take this discussion further in one of the future sessions.
Yes, sir. Thank you, sir.
Thank you. Thank you, everybody.
Thank you,
Thank
sir.
you, Rajiv. Thank you.